just under 10 minutes, so we can take some questions. Let me throw it up to the audience. Mark?
Maybe start with the cardiovascular one, if I may. So in terms of your sort of morphogenic data predicting cardiac outcomes potentially, I mean, it's the big question for polygenic risk scores, which is actually what can you do with the information? And so do you think these are just basic biology of the heart that we're not going to be able to interfere with? I mean, so you could take hypertrophic cardiomyopathy as an example of that in a way. How do you think they're going to fit into? We can do something with lipid, we can do something with diabetes, we can do something with hypertension. But these things that are changing the sort of morphology of the heart, do you think there's anything therapeutic in them?
Sort of the genetic contributions now, as you're saying, for hypertrophic cardiomyopathy. Clearly, certain individuals have these driving mutations, but then others have this polygenicity associated. So they've got lots of small other genes with small effects. And clearly then that polygenic, I'm not sure if I'm answering your question, so that polygenic score that people have created have been able, to be able to demonstrate you can identify people at higher risk and also potential carrier status as well.
I suppose the question, though, is it's really interesting and it's important to know, but is it actually going to matter for medicine? And maybe the answer is we don't know yet.
So I think clearly all of us know that from the genetic basis, what we're finding, what the candidate genes are and the mechanisms to develop the new therapies towards those targets is one aspect of it. But clearly there's a lot going on and potential systems to target. I'm not perhaps getting exactly your question. Maybe I'm just not answering.
I guess the question is,
sorry.
The genetics may change the C statistic in terms of the calculation of risk. It may provide some incremental value, but the incremental value may not be related to modifiable risk factors, at least in the context of what we can do today. So you may tell somebody they're at higher risk, but there isn't much we can do about it.
Agree with that. Okay. I think it is just sort of helps to identify, but what it actually can achieve.
Okay. I may just ask Nick a question as well, because the radiology predicts outcomes with knees and hips. What's happening with backs?
That's an interesting question, and I think the whole point with knees and hips is that you can do something about it definitively. I mean, we have a definitive outcome which represents severe disease, which is joint replacement. That's much harder for backs in the sense that, I mean, what would be the outcome? It would be back pain. That's probably more difficult to capture in that prospective sense at a large scale. So I think in the field of osteoarthritis, I'd say that what we can do with backs is behind what we can do with knees and hips because of just the construct of the exposures and the outcomes. What we have got, and what is increasingly well worked out in backs, is vertebral fractures. So the team in Manchester have defined vertebral fractures on the lateral images in the UK Biobank. That's a really definite phenotype that we can use as an exposure or an outcome. So I think in fractures, back absolutely critical and a lot going for it. I think in osteoarthritis, it's an important question, but it's hard to get such a definite handle on as it is for, say, hip and knee.
Question here. Yeah.
Thanks. It seems like with the brain data that Fidel presented earlier and with Wendra's data earlier, the IDPs have helped the whole community to join in the investigation and really get on board with imaging data as non-imagers. Patsy and Jakob and Nick, you all presented kind of higher dimensional shape models, and so did others earlier. How do you, with those high dimensions that kind of lack maybe the medicinal kind of labels that we might have had previously, how do you kind of anticipate bringing along the rest of the community for the rest of the kind of investigative journey?
I think there's two aspects to that. One is the research and one is the clinical implementation. I think with the joint shapes, there is a message there in terms of what the joint shape corresponds to in terms of disease. So you can look at the shapes, and they do correspond to phenotypes which we know at their extreme forms, are linked to osteoarthritis. And I think that's important clinically in terms of making people believe that this is something that matters clinically. Clinically, it's about the implementation and proving that implementing identification of people on this basis and then intervening will change outcomes. We've done that for osteoporosis, for screening for high fracture risk. We need to do that in this context. And then I think in terms of research, it's really making sure that the resource is known about, and these are examples of what one can do. I mean, I think from my point of view, one of the questions earlier was, what's the thing that's really surprised you about this? For the DXA, I'd always thought of that as a number, bone density. Actually, the thing that's been of real interest to the bone and the sort of genetics and engineer community are the images. And it's, for me, it sort of completely turned it on its head as to what you can get out of these data. And I think just publishing, dissemination, getting the message out there that this resource is there and it's usable is important for research, but there's a whole set of other stuff we need for clinical implementation to make a difference to patients.
There was one thing I was going to ask you, actually. I mean, I was quite surprised just the shape dimensions themselves were able to make such an impact. I mean, do you impute the incapacity and the pain that's associated with the condition? Because surely that must have a huge impact on your outcome in terms of whether you make a decision.
Yes. So, I mean, there's a whole host of complex considerations with using joint replacement as the outcome.
Yeah.
It's a definite outcome. It's the thing we can use. But I agree at the clinical end, there's a whole load of other considerations, like does the patient want it? How much pain have they got? Have they got access to a surgeon? So it's not possible to get a really good grip on that. But that is something that actually we can, through UK Biobank, get something of a grip on, because we've got a wide geographic range, we've got a wide socioeconomic range, we've got different ethnicities. We can map incidence of procedures according to those various strata. And that can give us an idea about access to care. And I think that's one of the really valuable things about the vast scale of this resource, is that we don't just get the exposure outcome models, we can set them in the context of that sort of landscape that varies across the country and across socioeconomic strata.
Excellent. One at the back.
Thank you. It was a wonderful presentations again. I have a little bit of a nasty question, I think, toward Jakob Weiss. And that is more the question, if you work in aging, of course we all have aged already. For us it's too late to stop it. How well are we doing with predicting aging as a prognostic factor? So not predicting your risk of being older or younger, but rather saying, okay, if I do an intervention either with a GLP-1 or whatever I'm targeting, a diet, what will I see in the changes?
That's a good question. I'd love to answer, and I think this is where we have to wait for the follow-up data, because obviously, of course, right now we have the cross-sectional data and we have the outcomes, and we can look at associations, but we don't have the longitudinal change where we can see if something increases or decreases. This can help or change risk, and whether you can intervene in one or the other direction. We did a preliminary analysis in a different data set where we had longitudinal data and found that an increase in liver fat by 5% increases risk, and a decrease in liver fat vice versa. But that's just the first hunch, and I think there's a whole new field going or opening up once the follow-up data is available. And maybe a quick add-on to your question, because I think we have to look at this from a critical side as well, only because we have these methods now and we have the data now and we can extract or quantify basically everything out of these scans, doesn't mean it helps or someone wants to know about it. I think bringing it to the attention also for the patient might be a good thing, because there's a lot of research out there that patients understand an image better than an abstract risk score in a percentage number. But there needs to be a close collaboration with the clinician, because we can throw out numbers every day. We scan a couple of hundred CTs and MRIs a day and can extract all these measures. But if no one wants them or no one knows how to use them, we shouldn't do it, because it can create more confusion than help in the end.
Well, thank you very much. We're going to have to wrap up for another short break, but just reflecting on what's been said. I mean, medicine is very binary in many ways. You either have disease, you don't have disease, we treat or we don't treat under certain circumstances. What's come across very obviously from this phenomenal work is the huge variation, human variation, even within the boundaries of what might be called normality, and indeed it begins to question what normality is as we go forward and begin to try and define people on different trajectories of disease, because as we've recognized, preventing the evolution of disease is probably going to be more important than ever in future as populations are aging, and therefore getting a handle on the factors that accelerate the trajectory of aging or can decelerate it and prevent the evolution of clinical manifestations of disease is going to be really, really important. And this kind of investigation is going to be important. And finally, I think the idea that we're going to potentially invest, I think, in a much earlier study in teenagers and beyond, which I hope will incorporate this kind of imaging technology going forward, would be really valuable to get an earlier handle on the disease trajectories, because I suspect some of it happens much earlier than we realise. Thank you very much. It was really, really stimulating.